So beginning with the history, the patient's name is Mr. ABC. He's 45 years old and he's a male and he works as a farmer. So the importance of him working as a farmer is because being a farmer, he'll be outside in... hello, am I clear now? The importance of him being a farmer is that because he's a farmer, he'll be outside in the sunlight for a very long time. So he'll be exposed to the UV light, which makes him very susceptible to get pterygium. And the socioeconomic state...
Just a minute, Aashna. Just a minute.
Aashna, could you please go a bit slower?
Yes, sir.
Aashna, can you hear me?
Yes, ma'am.
Yeah, just present the case now. We'll discuss it in detail afterwards, okay? You present the entire case first, then we'll discuss the relevance of each and everything, all right?
Okay, ma'am. Okay, ma'am. The occupation of the patient is he's a farmer, and the socioeconomic status is he belongs to the lower class of the socioeconomic status according to the Kupuswamy scale. The chief complaints of the patient is the growth of a pink fleshy mass in the right eye since 3 months, and there are no other complaints. The history of presenting illness is patient was apparently normal 3 months back when he developed a growth in no associated symptoms of redness, pain, diminution of vision, or colored halos were seen. The past ocular history, there is no history of trauma, squint, or lazy eye, or any other significant past ocular history. There is no history of trauma, squint. There is no history of usage of spectacles, eye drops, or any ocular surgery. In the past medical history, there is no history of diabetes, hypertension, rheumatoid arthritis, sarcoidosis, asthma, eczema, or any other significant past medical history.
Yeah, now you can present.
In family history, there is no significant family history related to pterygium. On examination, starting with general physical examination, there is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, and no edema. Vitals, the temperature is 98.9 degree Fahrenheit. Blood pressure is 130 by 80 millimeter of mercury. Pulse is 70 beats per minute. And respiratory rate is 17 cycles per minute. Systemic examination. In the CNS, there are no focal neurological deficits. In CVS, the S1 and S2 are heard and no murmurs are heard. The RS, normal vesicular breath sounds are heard. Per abdomen, soft and non-tender abdomen could be palpable. In ocular examination, the head posture was normal. There was no facial asymmetry. The ocular posture, both eyes were aligned, straight, that is orthophoric. Starting with the visual acuity done by Snellen's and Jaggers chart respectively, the distance vision is 6 by 6 in both the eyes. The near vision is N6 in both the eyes. Eyebrows and eyelids are normal in both the eyes. The conjunctiva, palpebral, bulbar, and forniceal conjunctiva is normal, but there's a fold of the conjunctiva seen in the right eye. The cornea examined under the bright light, the height is 10.3 millimeters in the right and the left eye, and the width is 10 millimeters. The size, shape, surface, sheen, sensation, transparency are all normal in both the eyes. The sclera is normal in both the eyes. The anterior chamber, the contents are clear and the depth is normal. Iris, the color is normal. It was black in color, and the pattern seen is also normal. The pupil was round, regular, and reactive to light. The size, shape, the size and shape of the pupil, there was a single pupil in both the eyes, on the right and on the left eye. Response to light, the direct reflex was present in both the eyes. The indirect and color signals left eyes. Upon digital tonometry, fluctuation was present in both left and right eyes, means it was normal. Coming to the summary of the case, the patient deserved growth. On exam, he was found to have pterygium, and the left eye was normal. The possible differential diagnosis could be pseudopterygium, pingicula, limbal dermoid, and episcleritis. The provisional diagnosis is pterygium of the right eye, and the left eye is normal.
So here we have a patient who's 45 years, and the sex of the patient is male and occupation is farmer. So we have importance on each of these. So would you like to explain what importance is it with the age, with the gender, with the occupation?
Yes, ma'am. As far as the age is concerned, pterygium is seen more in the older age patients.
Yes.
So he is like more than middle age, so he's an older age patient.
Very good.
And it's more prominent in males. It's seen more prominently in males.
Why so?
It's seen that the incidence is more in males.
Yeah, so why? Like, is there any logic behind it? Yes. So I think we can see it in the chat box. They say males work more outside. So outdoor activities and work-wise when it is concerned, females are restricted to household activities more and males are more restricted to outside work. Once you start working outside, you get exposed to
sunlight, and it has the UV light.
UV light. UV light. That is known as a known factor, right? That is a risk factor. I can see Ramya. Can you hear us?
Yeah, yes, ma'am.
Okay.
Yeah.
So we are back to slide 1. We were discussing the gender, why it is important. And then coming to occupation. Why you think occupation is important, Aashna?
As he's a farmer, so again he'll be working more hours outside and will be exposed to the sunlight. So.
Okay, so here there is a question. There's something called pterygium belt. Can somebody answer what is pterygium belt?
Ma'am, in the equatorial region, like in the earth, near the equatorial region, 45 degrees north, from 45 degrees north to 45 degrees south.
Okay, I don't know where you got that 45. It's actually 30.
Okay.
It might vary from studies to studies. So they say 30 degrees north and 30 degrees south of the equator. And where is India?
Okay. It's more common in Eskimos as well. Why do you think that is there?
Yeah, that is also a question.
They do not. Eskimos don't come under the pterygium belt or anything. But yeah. Somebody's answered it. UV reflection from the snow and ice. Yeah. And Aashna, while you were presenting this, you said Mr. ABC, 45-year-old male. Okay. So when you said
with the
Mr. ABC, you did not mention like that. You can start as a 45-year-old gentleman, Mr. ABC, working as a farmer. That gives a more nice introduction to your case presentation. Okay.
Okay, ma'am.
Can you hear me?
Yeah.
Yes, ma'am. Okay.
Yeah. Okay.
We'll go to the next slide.
Yeah.
We'll run short of time is what my concern is.
Yeah.
Okay, so the chief complaints.
There is actually no need to write as no other complaints in the chief complaint. Okay. So you can just write what the complaint of the patient was when he or she presented to you.
Okay, ma'am.
Growth of pink fleshy mass in the right eye since 3 months, that is fine. The word that no other complaints need not be written in the chief complaint. Because you're
Okay.
telling what he came with, okay?
Okay.
Regarding history of present illness, apparently normal 3 months back when he developed a growth in his right eye, which was inferior, causing no difficulty in vision, no associated symptoms.
Yeah, when you come to HOPI, right eye insidious in onset, yes, pterygium is insidious in onset. You don't notice it suddenly because when it is too small, patient will not really notice it as pterygium. So only when it becomes very prominent, then they will date it back. Okay, I had a small, I don't remember when it was and all. And gradually progressive pterygium. What are the? How do you classify pterygium based on the progression stages?
It's regressive and progressive.
And is
Stationary.
stationary phase. There's no regressive. It's actually atrophic. That it doesn't progress at all. Okay.
Okay.
And causing no difficulty in vision. So we assume over here that the pterygium is quite in the early stages. It's not approached too much to cause vision diminution of vision. How will you explain diminution of vision in a pterygium?
If it started obstructing the pupil, the person.
That is in the later stages. If it is in the early stages, is there a possibility that it will still hamper your vision?
It might be pushing on the pupil and causing visual defects.
No pupil. It is at the limbus. Okay.
Okay.
Yeah, but it still can cause some blurring, some quality loss of vision.
Astigmatism?
Yeah, very good. Astigmatism. What astigmatism would explain here? How would you explain astigmatism here? Like what mechanism?
As you told, it will be pushing on the limbus. So because it will be pushing on the limbus.
Pterygium doesn't push. Pterygium is a mass. Okay, could you just define what is pterygium?
Pterygium is a fold of conjunctiva which like overgrows the conjunctiva and grows towards the limbal cells.
What is the histopathology?
It's conjunctival in origin. So the layers of the conjunctiva.
What is the degeneration?
The limbal stem cells.
Elastotic degeneration and subconjunctival tissue fibrosis. So there is fibrosis. So it contracts. So it pulls, as in it flattens that cornea. So if this is your cornea and if you have a fold of pterygium growing, this will contract and it will flatten this cornea. So this meridian will become steeper and this will become flat. So you will have with the rule, mostly with the rule astigmatism. There's at times it is also known to cause against the rule and at times oblique astigmatism as well. Okay. So if somebody asks you how would you explain diminution of vision in the early stages, then this is the explanation that it will cause astigmatism. Most common is with the rule astigmatism. Against the rule astigmatism is also found and oblique astigmatism is also found. The hypothesis being it contracts. So it flattens the cornea in that particular shape, in that particular region. So which pterygium is more common, nasal, temporal?
Nasal pterygium.
Nasal pterygium is more common. So I think you can mention in the chief complaints only where, or probably in your examination, where would you see nasal or temporal? Okay. And why? What is the explanation why nasal pterygium is more common than temporal?
Because the nasal side is more exposed to the sunlight, it's more common because it gets reflected from the nasal bone, and also the tears get accumulated in the lacrimal duct, so they push upon it, which can also cause pterygium.
That is probably the tear flow. Okay, fine. What you said is right. Okay, if for everybody else to understand, this is your eyeball, this is the nasal side, the temporal side. Temporal side, you do not have anything obstructing so that the light rays which fall will again reflect back. But in the nasal side, you have nose. So when the sun rays fall, first of all, it is receiving the normal sun rays as well, and as well as the one that is being reflected from the nasal bone. So it says approximately 30%, it receives more than 30% of the light that is in the temporal side. Okay, and also there is another hypothesis, this is for PGs. This is your eyeball, the temporal, inside the eyeball you have lens. So that also acts as a reflecting medium. So once the rays fall on the temporal side, it reflects back and it also travels to the nasal side only. So that's how you see more common is nasal pterygium more than temporal. Okay. And then you say no associated symptoms. So like redness, yes, pain, diminution of vision, that is how you explain. In the late stages, there will be obscuration of the pupil and then you will have diminution of vision. But in the early, it is astigmatism. Then colored halos. Why colored halos?
To rule out the other conditions, like there'll be a lot of differential diagnosis. So
Like?
to rule out the like pseudopterygium or episcleritis.
Okay, since you have already mentioned pseudopterygium, what is the difference between pterygium and pseudopterygium?
Pterygium does not have inflammation, but pseudopterygium is an inflammatory condition.
Okay. How do you differentiate them clinically? What are the causes and how, why?
Pseudopterygium can be caused by any underlying inflammatory condition,
Okay.
but pterygium, the causal reason could be the UV rays or the age factor.
Okay.
Also, pseudopterygium is like only stationary, but pterygium has other stages, like we told.
It can progress or it can
and regress, or it can stay stationary.
Yeah. And?
Or stationary.
And I mean, I'm looking for more differences.
There are 5 differences, no? There are 5 differences.
Yeah.
There are 5 differences in your textbook, right? 2, 3 columns, and then pseudopterygium, pterygium. All you should be able to list everything. So you told it's non-inflammatory.
Yeah.
Non-inflammatory. It is stationary. Then third one, they are answering in the chat section. If you just look at it, somebody said about probe test. What is probe test?
Yeah, very good.
We can
Aashna,
pass
what is probe test?
We can pass the probe under the pterygium, but it's not possible in pseudopterygium.
You can pass it under pseudo. You can't pass it under pterygium. Okay, you just have to understand. Don't mug up. Okay. See, you have what is a pseudopterygium? Basically, anywhere ulcer in the cornea, peripheral ulcer. So a fold of conjunctiva, bulbar conjunctiva, can go and get adhere over there, and then it can form pseudopterygium. This is just for you to understand. Simple. Okay. So there is this gap in between. In pseudopterygium, when it attaches, the fold of bulbar conjunctiva, when it attaches, there is a gap. So you can still pass a probe, that is a glass rod. In case of pterygium, it is the subconjunctival tissue that has undergone these elastotic degeneration. So there's no space in between for you to pass any probe. Okay, so that's where you can't in pterygium. The other differences, okay, the site
difference.
Site.
The pterygium can be seen in nasal side, but that can be seen in any side. Also, pterygium is more common in middle and older age people, but pseudopterygium can be seen in any age. There is no age.
So the site, when it comes, you have to explain. It can be seen nasal as well as temporal. These two are more common. Okay, they're always in the horizontal plane, whereas pseudopterygium can be seen in any clock hours. To be more specific, it need not lie like horizontal only. Even if it is coming from 3 o'clock or 9 o'clock, no, it might not just end up in the center. It might go inferiorly, or it might go superiorly, or it might come from inferior to up, something like that. It will not be in the usual place where you see the pterygium. Okay.
Also, we can tell that recurrence is common in pterygium, but it's not seen in pseudopterygium after the surgical.
Yeah, very good. Okay, we'll move on to the next slide.
Yes, ma'am.
I think there's a lag in Ramya's video. Okay, past ocular history, no history of trauma, squint, lazy eye. Why is it significant?
It can be a cause for the pterygium to occur again.
Pseudopterygium, right? Trauma and all will have pseudopterygium. So you're ruling out pseudopterygium. Why squint, lazy eye?
We can know if there are any plaque in the nerves or the muscles, ocular muscles.
But he's come with only pink fleshy mass in the eye, no?
Yeah.
Why would you ask for past squint and lazy eye? This is, I think, in view of operation. Okay, after you operate, the patient should not have any palsy. Mostly medial rectus is the most prone for injury when you are operating on pterygium. Okay, so sometimes you might not differentiate the subconjunctival tissue. It is also vascular. The muscle is also red and fleshy. This is also pink and fleshy. Sometimes there are chances when you do extensive resection, no, you might injure medial rectus. The most common palsy is MR palsy, so your eye will be in the lateral. All these should be ruled out so that the patient will not sue you for causing such a damage later on. Okay, he should not, because it's a possibility. And also about the lazy eye, why? The drop in the vision might not be due to pterygium, it might be prior. He might already have a lazy eye, that is amblyopia. Okay. Then no history of glasses, eye drops, ocular surgery. So all comes under that only. Spectacles, why?
To see if already he had like loss of vision or there was a lack in vision, he was already suffering from such condition, and it was not actually due to the pterygium.
Yeah. And what eye drops would you say?
Anti-allergic eye drops or eye drops which help in the lacrimation. The one that
He
normally
should not
the
have dry eyes.
okay.
Okay. Because after you do surgery also, the patient is still prone for dry eyes. You have to weigh the out risk. And okay, the next slide. So somebody, okay, we'll come back to the chat section and answer all the queries later. We have lost Ramya actually. So,
Ma'am, I'm there
oh, you're there.
through the
Your
phone.
video
Yeah.
is okay.
No,
Okay.
I logged in through the phone, ma'am, now.
Oh, okay, okay.
Okay.
Welcome back. Yeah. We'll see the chat section later.
Yeah, sure, ma'am.
Okay, then past medical history. Ramya, you want to take over?
Okay, so you asked about diabetes, hypertension, rheumatoid arthritis. Any specific reason for only these things?
It
You
can
can just
lower the
mention.
immunity of the patient.
Sorry?
It can lower the immunity of the patient.
Okay, so you can just tell that no chronic illnesses and diabetes, hypertension. That much would suffice.
Yeah.
Okay.
Because none of these have direct correlation with pterygium. Family history, is it important?
It's not genetic, so it's not important.
There are theories which says it is genetic also. The tumor suppressing P53 gene is known to cause pterygium, and it is known to run in families. So there is a hypothesis that's in the PG level probably. You can just say yes, it is known. You might not be asked about its inheritance pattern and all, but yes, if they ask you more specifically which gene, then you can say tumor P53 suppressing gene. Okay. Next. On exam, we can skip this. I think Ramya, you want to talk about it? Anything?
Yeah.
Yeah. Okay.
No, just that you have to write a protocol sentence that patient is conscious, cooperative, well oriented to time, place, and person, moderately built and nourished.
Okay, ma'am.
So you have to write those things in your case sheet.
Okay, ma'am.
Fine.
Yes, ma'am.
Yeah.
Vitals.
Yeah, that's fine. Vitals is fine, and then even systemic you have to just mention. Some examiners will ask you whether did you take the BP and all those things. So make sure you have a BP apparatus with you before saying yes.
Okay, ma'am.
Okay. Yeah. So we'll go to ocular examination.
Yeah.
Okay, so last time when we had discussed, we had not discussed in detail about Hirschberg's test, and probably we'd asked everybody to read and come. So even in the chat section, and Aashna, you also, you can explain about the Hirschberg's test and how did you say that it's orthophoric?
In the ocular posture, both
I request others to kindly mute themselves. Okay.
Yeah, I think now we can proceed.
Yeah.
In ocular posture, we can see that both the eyes are aligned straight and there is no strabismus. And the fact that there is no strabismus is measured by the help of the Hirschberg's test.
Yeah, so here, when you say ocular posture, yeah, you mention orthotropic, not phoric. Okay.
Okay, ma'am.
If you see, what is the difference between tropic and phoric?
Orthotropic means it's normal in the position, the posture.
Okay. Then phoric?
Phoric.
You do it by cover uncover test. There's something called manifest squint and latent squint.
But somebody's squint.
Yeah. So, okay, we can proceed. So there's something called manifest squint and latent squint. Manifest squint is that is manifesting and you can see the eye is squinting. Okay. In ocular posture, you will see only manifest squint. For phoric and latent squint, you have to do detailed Hirschberg cover, uncover, and then detect if there is any latent squint present. Now, what do you mean by ocular posture? You see the posture of the two eyes, if they are aligned centrally or not. So it has to be tropic. If there is no manifest squint, then it is orthotropic. If at all, if you want to make out if there is any latent squint present, then you do that cover-uncover test. And then you detect if there is any latent squint, if the eye moves and then comes back to its to take up fixation. So when you mention about ocular posture, it's always orthotropic. Okay. And head posture, yeah, central or okay. If you say normal, I think it should be acceptable.
Okay.
Okay. Then vision. You say your vision is good in this patient, so we presume it is still in the early stages and it has not caused anything. There are chances it will not cause, okay? Astigmatism, even if it is up to some one dioptranol, the patient will still accommodate and will still be reading 6/6.
Okay.
Okay. And near vision, unlikely to be hampered unless it is encroaching the pupillary area. Okay, next slide. I think Ramya is there.
Yeah, ma'am. Actually,
okay. Yeah, you want to say? Yeah.
Yeah. So, Aashna, what is the most common type of astigmatism in this, like in pterygium patients? Like, if you were given a choice in your MCQ exam, okay, which is the most common refractive error with this patient? So you have options as with the rule, against the rule, oblique, all of the above.
With the rule.
Very good.
See, I gave you 4 options: with the rule, against the rule, oblique, all of the above.
If all of the above is in the option, can be all of the above.
You have to write. If all of the above is there, then it's all of the above. If there is only with the rule, so it goes in the decreasing order of first is with the rule, then against, and then oblique. Okay.
Oblique. Yes.
Yeah. Okay. So why do you think with the rule is more common?
Yes, please. Explain.
You're good. You're going good.
Yeah.
When the pterygium is pressing upon the cornea.
Okay. In which meridian?
In the lateral meridian.
Horizontal.
Horizontal meridian.
Okay.
In the horizontal meridian.
Yeah.
So it causes with the rule. If it's not in the horizontal meridian, if it's in the other meridian, it will cause against the rule.
Yeah, so basically you told, when you were telling the difference between pseudopterygium and pterygium, you told no, right? It's more common in the nasal and temporal sides. And
yes,
that's why if you have a tissue there, it is going to flatten the cornea that in the horizontal meridian, which will cause the with the rule. So why is it more common on the nasal side? Was it discussed? Like if you were given an option.
Ma'am, you're
not audible. Yeah.
Now?
Yeah, better.
Yes, ma'am.
And am I audible now?
Yeah.
Yes,
so I was just asking you why it is more common on the nasal side.
Ma'am, because the sunlight falls more on the nasal side, and on the temporal side there are no obstructions. But
sunlight
on the nasal
doesn't do discrimination. No, I'll fall here, I'll not fall there.
On the temporal side, there is nothing to obstruct. But on the nasal side, the direct sunlight also falls and it gets reflected from the nasal bones also, from the nose also. So the amount of sunlight falling is more.
Yeah, you're partly right. That one part is that the nose reflects a lot of light. The second part is also that there is in the AC, right, in the anterior chamber, there's going to be reflections, and that also more gets concentrated towards the nasal limbus.
Yes, ma'am.
Okay, regarding your vision, you've written distant vision as 6/6. Most commonly, all these examiners will ask you, what do you mean by 6/6 vision? Like, how do you explain this 6/6 vision?
Ma'am, the distance of the patient from the Snellen chart is supposed to be 6 meters, and there are, let's say, there are the English letters written over it. So, if the patient is able to read like the lowermost letter, so that's supposed to be 5. So that means that the person had to read those letters at a 5-meter distance, but he is reading at a 6-meter distance. So he has a better eyesight than normal people. So it would have been 5/6. But then 6/5. But now, because he's reading the second last line from the Snellen's chart, which was supposed to be read at 6 meters from a normal patient, so the vision is 6/6. If he was not able to read the second last line also and further above, the vision would have been 6 by 8, 6 by 12, and so on.
There's no 6 by 8, okay? There's 6 by 9,
Okay.
then 6 by
6 by
12,
12.
okay?
Sorry.
So what you're going to say is that this is the, like 6 by 6 is the normal vision. That means what the normal person is supposed to be reading at 6 meter, even this person is reading at 6 meters. It's as simple as that, okay?
Yes.
If you had a vision of 6 by 18, what a normal person would read at 6 meters, this person is taking lesser, like he needs less distance to read that. That means he's having some refractive error. Okay, so in this you've written about distance and near. So you can go to the next slide. In eyebrows, eyelids and all, they'll ask you what are the abnormal things in the eyebrows, eyelids and everything. So in case your examiner is in a mood to talk about all these things, they can ask you about mederosis, tylosis, dystrichiasis, entropion, ectropion, everything. Okay, so just have a note about all of these things. Yeah, you can continue.
Okay, so here you've written normal.
Aashna, your case is what? What is your case?
Pterygium, ma'am.
Where is it in your examination?
You spoke about it, yeah, but you have missed it on the slide.
Okay, this is very, very important for you to write what the finding, what you're telling it in the case sheet, okay?
Yes, ma'am.
So,
how would you describe your pterygium now? We don't know. You've seen your pterygium, like your patient. How would you describe it?
It will be a triangular mass in the shape, and it will have a cap, head.
No, but how would you examine, like in your torchlight? You will not say head cap, and those are parts of pterygium. But how would you describe a mass in the nasal side to prove it that it is pterygium? Because for now, I'm just considering it could be pterygium because it is most common. That's the only reason I have. In my examination, I need something. Otherwise, I will jump towards other differentials.
There's a fold of conjunctiva which is protruding from the nasal side towards the limbus, and it's pinkish in color and it's triangular in shape. It's a wing-like mass.
More appropriate is wing-like. I don't see
a triangular wing-shaped fold of conjunctiva from the nasal side is extending up to the limbus. You can even say approximately how much, okay? And which is pink in color.
Your pterygium is at the limbus?
No, it's not yet at the limbus because we did not find any astigmatism. So.
No. I'm asking your finding. It might not. See, it's not a rule he should have flattening and he should have astigmatism. And I told you up to 1 diopter astigmatism, he can still accommodate and read 6/6. Forget about all the. Did you see? Like we are genuinely asking how much was the pterygium. Based on that, you have grades.
It was till the limbus.
At the limbus or beyond the limbus or
at the limbus.
Still ahead of limbus?
At
the limbus. It stopped at the limbus.
Yes.
Okay, so how do you grade it? Stage it.
It was stage 2.
How? You tell the stages?
Yeah. Please explain.
Because it didn't cross the limbus yet, so it can't.
It's just describe the stages.
Stages.
What is stage 1, stage 2, stage 3?
1 second.
Anybody in the chat section also can reply.
Yeah, please.
Okay, there was, I think in the theory class also we had discussed there are 2 classifications, one by Tao et al., one by another Shao et al., depending upon where the extent of limbus is. Okay, Rishabh says stage 1 is before limbus.
Okay.
Then
stage 2 is just on the limbus. And stage 3 is between the limbus and the pupillary margin. And the stage 4 is it's protruding towards the pupillary margin.
As far as I know, there are only 3, grade 1, 2 and 3, and 1 is at the limbus, 2 is between the limbus and the pupillary area, and 3 is when it is approaching the pupillary area. Also, there is another classification which says it's atrophic, intermediate or progressive pterygium. Okay, so all those things had to be mentioned in your case sheet. So if it was a progressive pterygium, how would it be? If it's an atrophic pterygium, how would it be? So all those characteristics should have been written in your case sheet, saying that okay, this is a vascularized or a non vascularized mass or a fold of conjunctiva arising from the nasal side of the bulbar conjunctiva over to the cornea or over to the limbus at this clock hour, probably you can say at 3 o'clock or something. And then you can even mention that approximately about 2 millimeter in size or something like that you can mention, okay, instead of writing normal. And you don't have to write that in brackets, palpebral, bulbar and phoenicial, okay.
Okay, ma'am.
Yeah. So Ramya, would you like to just explain them how the stages of pterygium, like how will you say clinically, whether it is atrophic or progressive or in the intermediate stage?
Yeah. See, in a progressive pterygium, you would have a fleshy mass which is more vascularized, and it will be very striking feature for you. It is a fleshy mass and it's vascularized. In an atrophic, it is very thin, just a little fold of conjunctiva just present, which is not really vascularized. So the more vascularized it is, the more fleshy it is, the more chances of recurrence also is present. So when you're operating, you have to know whether it is an atrophic or a progressive, and the progressive one is also more commonly it causes the diminution of vision, like it does cause the astigmatism also. So you need to know the staging. Atrophic, you can actually leave it like that itself. It doesn't do much harm to the patient. You need not post them for surgery immediately, okay.
And
Anything
how
else,
would
ma'am?
you say it on like slit lamp if you had to see? For them it is torchlight. How would you say it is atrophic, progressive, or in the intermediate form, stationary?
You look for the vessels, ma'am.
The vessels?
The conjunctival vessels.
No.
And the episcleral vessels.
Yes.
So if you can see the episcleral vessels, then it is atrophic. If you are not able to see the underlying episcleral vessels, that means the congestion and the whole fleshy mass is only on the fleshy
it is
conjunctiva.
Progressive. It is very thick, so it obscures the underlying episcleral vessels. Whereas in the atrophic stage, it is so atrophic and thin that you can actually make out the normal episcleral vessels. Okay. Very good. Next.
Okay. So cornea, you've written it as 10.3 and 10. How under the torchlight you measured this, yeah?
For UG level, I don't think, this is not required. You can just say cornea, how do you, you've written size, shape, surface, sheen, sensation, transparency. So under these, if you have written all these normal, sheen is what? What is shape? Normal shape? Yes.
Yeah.
There was no defect or abnormality present. So
now what defect or abnormality in shape would you see? But what is normal shape? They'll definitely expect you to know what is normal shape. It's okay, don't panic. You can just say whatever you've seen.
I just, ma'am wrote it normal because I couldn't see any abnormality.
No, you can just say circle, oval, whatever you feel like you tell.
Yeah, some shape. Give some shape to the cornea.
Okay, it's circular in shape.
No, it's not circular. See, you have only written 10.3 and 10, so there's some discrepancy.
It's
no,
Is it elliptical? Ma'am, can it be elliptical?
Okay, there are many people answering.
Yeah.
Watch class and yeah.
But elliptical actually, because you don't see the whole of it.
Also, it is more thinner in the center and a little more thicker in the periphery. All that will come. Okay, I think that's why somebody is written as watch glass. Okay. Also, do not mention this in torchlight examination. Okay, they might catch you saying, "How did you see? How is it accurate? How can you say it's 10.3 only? Why not 10.4?" Things like that would come up. So do not land yourself in trouble.
Yeah, you can just say size is normal. So what abnormal size will you see in cornea?
The height could have been increased.
It's either megalocornea or
microcornea, right?
microcornea. So
When
here
do
in
you
your
call-
patient, you don't have.
Yes,
Yeah.
ma'am.
So how do you define megalocornea and micro? That's what Ramya wanted to say. Yes.
Yeah.
Yeah.
Prolate to whoever that small lymphocyte
So
is, it
when
is
the
prolate.
height of the cornea is more than the
Yeah. People are answering megalocornea, correct? Good. Yeah. Perfect.
Yeah. So Ramya, would you just want to
Yeah.
summarize how megalocornea and microcornea based on?
Yeah, it's based on the this thing, okay? The shape. Usually they tell if it's more than 13, it is megalocornea, and less than 10 is micro. Okay, microcornea can be associated with so many of the syndromes.
Yeah.
Basically, pediatric ophthalmology. Okay, when you have a reference from the pediatric department, they usually ask you to measure the corneal size and tell you they'll suspect some syndrome, and then they'll ask you all the other features. So when you're writing anything normal, be prepared to answer what are the abnormalities there in your case sheet. Because it's a simple normal case. Every time they can ask you in any way, what is normal, what is abnormal at each step, okay?
Somebody's written it very well, meganocornea at more than 12 mm at birth and more than 13 mm after 2 years.
Very
That
good.
is the very specific definition. Okay, then surface is normal. What surface is normal? There are no irregularities in the surface, okay? Then no deposits, nothing. Right? That is what you mean by.
Aashna, are you there?
Yeah, she's there.
Yeah.
You have unmuted yourself. No, you muted yourself. Unmute.
Am I audible now?
Yeah.
Okay.
How do you check for sheen?
Yeah.
How it reflects the light is the sheen.
Yeah, torchlight. So you basically shine it on the cornea.
Yeah.
And if you see that the sheen is normal, like if where else will you find it abnormal? Most commonly, even a normal person without any thing can have abnormal sheen. Where?
When there is a opacity in the cornea, anywhere.
No, but he has all normal cornea. That is what I'm saying. No opacity, nothing.
Anything to do with the tear film?
Fluke.
Aashna? Tear
Yes,
film?
ma'am.
And ma'am is trying to hint you towards anything to do with it.
Yeah, it's given up in the chat box also.
Increased tears.
Dry eyes.
Dry eyes. Okay. So the sheen gets affected when you have dry eyes also. Okay. Actually in your books and all, they would have written that you should do a placido disc and this, but you can answer saying that torchlight. Okay.
Okay, ma'am.
Because you would not have a placido disc there with you. Okay. Again, I think in your differential diagnosis, you have written as episcleritis also, right? So here you've written sclera normal. Sclera normal, no. And why do you want to write episcleritis in your TDs?
Pull that out, okay?
Okay, ma'am.
Sclera is normal, that's okay.
Sclera is normal, there's no pain. Patient is not complaining of pain at all. Very next to zero unlikely for the patient to come with episcleritis without pain and sclera being normal, okay?
What are the abnormal things you can find in sclera?
Yeah.
There can be inflammation or redness present in the sclera.
Okay, scleritis.
That's a very, vague term that you've told, inflammation. Ma'am is asking you what specific things you can see. You have to tell diagnosis.
You say sclera is normal, but sclera can be abnormal. One is scleritis, which you told. Yeah, there are so many
anything
abnormal
else?
Sclera.
Okay, somebody's answered staphylomas.
Foreign body deposits.
Foreign body is very rare. What more do you see? Change in the color?
Yeah, blue color. Okay, Kunj, the question is to you. Okay, 1 minute. Let Kunj answer right now. He said about blue color. Give the causes for blue sclera. Oh my God! This guy deserves Please send me your number, dude. I'll send you a chocolate. Siddesh. Blue sclera is seen in. Did you Google and write?
That's
Marfan
okay.
syndrome.
Either way, yes, Marple. I think
Did you
he's given
Google?
out a list over there. So,
Yeah, please, everybody, just that list is superb, okay? Yeah, you can send
osteogenesis
me.
imperfecta, correct?
Yeah,
No, madam. Okay, we believe you.
but you can still send me a number. I'll send you chocolates. Okay? Yeah, somebody's like, take screenshot. Good.
We had a
Oh, we
lecture
had
on
a
this.
lecture. Lucky,
Okay,
lucky.
okay,
Okay.
okay. Good, good.
Okay, so yeah, blue sclera, they'll ask you. Somebody also mentioned about icterius. Why do you see the yellowish discoloration in the sclera in icterius? Is the question. Why? First, before anything else, you would check for accumulation of bilirubin where?
Because of the elastic fibers.
Okay. High elastin level, more affinity. Yeah, good. So all of you together are making one answer. Very nice. There is high levels of elastin. There's more affinity for the bile pigments towards elastin. And also the color of sclera is white. So even a small tinge can be easily picked up. Okay, that's why you see first in the sclera.
Sclera.
Okay, what are the abnormal contents in the anterior chamber, Aashna?
What is the most common abnormal content in the anterior chamber? Normally you see aqueous, which is clear. What else can aqueous have?
Yes, ma'am.
So they are answering actually in the
It can have
chat.
pus or
Yeah.
Pus is hypopyon, but before that is AC cells, which you more commonly see in uveitis. No?
Uveitis. Okay.
Okay.
So AC cells,
Bad.
flare, hypopyon,
Foreign
uh,
body.
foreign, yeah. Even ACI will for some
Somebody's
examiners would
written
want
inverse hyphema, it's inverse hypopyon.
hypopyon. Okay, where do you see inverse hypopyon? Inverse hypopyon. Where do you see pseudo hypopyon, inverse hypopyon? Okay, difference between flare and cells. Cells are you will be able to see it only in the slit lamp. Okay, actually, flare is like the proteinaceous deposits. It will look like the Brownian movement. Okay, like how you would have read in the your 8th, 9th standard, how the dust particles move. No, just like that it will look flare. Cells you will be able to count. Okay,
Flare is just
malignancy is
a
what?
light phenomenon, which will obscure your iris and further.
Okay, wait,
Retinoblastoma, no.
wait.
Malignancy, no.
I think they're answering for pseudo hypopyon, ma'am.
Okay, no. It is inverse hypopyon. Normally you see
In
hypopyon inferiorly. That is your normal. What do you mean by inverse? You will see it superiorly.
I think
It is
Naveen has
against the
answered.
gravity. Yeah,
It's
somewhere
not
close.
silicone gel.
Yeah.
It's not silicone gel. It is just silicone. Okay. When we do a
Oil.
vitrectomy and then
Correct.
silicone oil is placed, that is an inverse hypopyon. Okay.
If
That can
by
be asked.
chance it is escaped into the anterior chamber from the vitreous, oil is lighter than water. That is why it floats, and that's how you see it superiorly and against the gravity. Otherwise, everything falls to the inferior part of the anterior chamber because of gravity.
Okay. Okay. Internal tamponade. Wow, very good. Yeah. We'll have to talk about RD if all this internal tamponade,
Yeah.
everything will come up. Okay. Yeah. Now you can move ahead, ma'am. Do you want to talk anything about iris and pupil? They might
Uh,
ask you the direct light reflex and all. Okay. What is the
Somebody had
pathway?
asked if there is any for Pterygium, how would you grade how much of pupil is obscuring or something? Is there any measurement or something to cause diminution of vision? As such, there is no
Oh, yeah.
measurement that we are aware of. I don't know if there is. Do you know about it? Some
No,
percentage?
ma'am.
No. It depends on your pupil. If it is mydriatic or myotic at that particular point of time. If there is dim light, then it will be mydriatic, and even that Pterygium which is not progressed actually could actually cause a lot of diminution of vision. And when
The,
it is bright light and when your pupil is constricted, you might actually be able to see it better because your pterygium will still be behind. That's a possible explanation, but I don't know the
yeah,
percentage.
there is one study, okay, which says that if the pterygium is more than 2 mm and more than 2 mm, yeah, the 2 mm in length and 5 mm in width, and total area is about 6.25, it causes about 2 diopters of astigmatism.
Correct.
Okay, that's all that I know of. Okay, the reference is I read it from Payment Book if anybody wants. So yeah, that is the only one that I've come across. Okay, we can move ahead. That is the pupil. In pupil, they can ask you about direct light reflex, the pathway for light reflex. All this is there in Qurana. Okay, please note those diagrams. Okay, optic nerve, optic chiasma, optic tract, all those things they can ask you when you are checking for the pupil. Even the light reflex pathway and the near reflex pathway also. Okay, both can be asked to you at that point.
Okay, so pupil number also she's written single.
Yeah. If you mention like that, they might ask you what is polychoria, where do you see double pupil, all these things can come up. So you yourself are leading the examiner to ask you certain questions by writing like this, okay? So you can just write round, regular, reactive to light, direct and consensual is normal or reactive, okay?
Yeah.
That much is enough. Okay, you need not mention about all these. Okay,
you don't know where it will go and trap you.
Okay, the pterygium, they'll forget about pterygium and all normal things. It will go up to full, okay, uniocular diplopia, till there it can go. Okay, so don't do those mistakes. Then yeah, you've written, next is lens. Okay, lens, I think we've detailedly discussed in cataract. Lacrimal apparatus, again, they can ask you everything regarding dacrocystitis there, okay? So basically what you're trying in Rho plus negative is you want to rule out any infection prior to surgery, if at all you're planning for a surgery. Now digital tonometry, I say that digital tonometry and even fundus examination is very much important in a patient of pterygium. Why is it?
To see if there is any abnormality present already inside the body, and it might not be because of the UV rays. That's it.
Sorry, come back.
The pterygium could be because of any other abnormality which was already present. So it could
How can pterygium occur because of any other abnormality that's already there in fundus? What do you mean by fundus? Fundus is nothing but retina. Okay, retinal examination is what I'm trying to say. In a case of pterygium, before posting for surgery, I would very much like to look at the fundus.
To see if we might not damage the fundus and its structure.
Why will damage? It's an extraocular surgery. We're not even giving an incision like, in the outer, like through the sclera or somewhere. Okay, we are just doing, it's a very extraocular surgery. Sometimes you just tell the anesthesia will be like, okay, I'll manage, you don't worry, just give me the fitness. Okay, so it's easier to do a pterygium surgery, not this thing, but I would definitely want anybody to look for the fundus or the retina before posting for surgery. Now, why is that is the question. Raised intracranial pressure, what do you want to see in, not intracranial pressure. I also told digital tonometry she's mentioned, I really appreciate it because I would want to know the IOP. Why? Not papilledema per se. Papilledema, yeah, obviously when you check, you will know if there's papilledema or not. Basically, the what I'm trying to say is you would want to know if there is any glaucomatous disc changes. Okay, even though there's normal tension glaucoma or any digital tonometry might not give you the results, but optic disc changes in glaucoma. Now, why do you think this is important for me to know before the pterygium surgery? What am I handling in pterygium surgery? Which tissue am I handling?
To see if the eyeball is not hard or soft.
No, that before. See, you're not getting the question, Aashna. Point is, what tissue am I handling during the surgery?
The conjunctival tissue.
Very good, conjunctiva. Yeah. So, how does handling conjunctiva differ if there is glaucoma? Is the question. Have you heard about trabeculectomy surgeries?
Yes, ma'am.
Yeah, so when there is a trabeculectomy surgery, if you are planning for a trabeculectomy in a patient with glaucoma, then you would want to preserve the conjunctiva to form a bleb. Okay, so if you want to preserve the conjunctiva in the superior aspect, you would not want to take a conjunctival flap from the same eye and put it for the pterygium. You do not want to sacrifice such a sacred tissue for pterygium than for glaucoma. Okay.
Okay, ma'am.
Correct, right? I hope others are also clear about it. Okay. Ma'am, are you there?
Yeah, I'm there.
Yeah. So you need to know that the conjunctiva, what you're going to cut, is it's very sacred. Okay. I'll repeat it.
Yeah, repeat it. Somebody wants it to
See,
be
if you
repeated.
have a optic disc change of glaucoma, okay, when you see the fundus, you can see some, okay, there are some optic disc changes of glaucoma. Then you would not probably want to take a conjunctival autograph from the same eye. Like, how do you take the conjunctival autograph from the superior bulbar conjunctiva, right? But you would want to preserve that for a trabeculectomy surgery, which might be indicated for this patient if at all he has glaucomatic disc changes. Okay, so you would not want to hamper the tissue there. So in those cases, either you can do a rotation or you can use an amniotic membrane graft. You do not want to too much, disturb the conjunctiva of that eye. Why not inferior bulbar conjunctiva? That will take it. Inferior bulbar conjunctiva is more exposed, okay? And even if you form a bleb during the glaucoma surgery, it is not as safe as your superior one. It is more exposed and more common to get infected. Can we take buccal mucosa? Yeah, there are
Amniotic
in the
membrane,
textbook
more.
they do say, but usually what I've seen is they do take only amniotic membrane graft or the conjunctiva from the patient
We'll
side.
come to that when we discuss surgery.
Yeah.
Yeah.
Okay, so I hope that clears the thing here. Yeah, we've exactly 15 minutes time, so we'll run.
Yeah.
Next slide. The ocular movements.
Why is it important?
In this case, yes, very, very important.
To see if convergence is taking place properly or not.
No, I'm not interested in convergence.
No, not convergence.
I want to operate a case of pterygium. Okay. So what am I specifically looking for? Strabismus, they say, diplopia. All this is vague, but what am I actually looking for?
Will the eye or the eyeball say stable while you operate, or it doesn't?
No.
Pterygium is more common in the nasal or temporal.
Nasal side.
Nasal
Which
side,
muscle is there?
Extraocular muzzle.
Yeah, they're answering in the chat.
I told you in the beginning, no, medial rectus.
Yes.
When we do
So medial
surgery, we are
rectus
more concerned.
as-
When we do extensive resection, the chances of damaging the medial rectus is high. So you want to see if the ocular movements are restricted prior to surgery or not. If it is restricted prior to surgery, it is not your fault that you have done something. Okay, so you have to explain the patient that it might still persist. We are not doing that surgery, it's a different surgery. He might not understand. A layman will not understand. He would think the pterygium itself is causing restriction.
Okay, and
In
when you
very
try
severe stages, yes, it might. When it involves the medial rectus, it can cause diplopia.
Okay, so when you're writing Dakshan's versions, no, you can just write free and full in all directions. Instead of writing present and normal, you can write free and full in all directions, or you can even put those arrows. Okay, like last time I think it was put in the case sheet, you can just put the arrows and mark it as present, and you can say free and full in all directions. Fine.
Okay, ma'am.
Yeah. Again, when you're talking about these vergences, no, they can ask you what is convergence, insufficiency, and things like that if they want to. Like if you're answering too well and they want to actually ask everything. Fine.
Okay,
yeah, come back. Come to your summary.
Yeah. The next slide, yeah.
So you have a gentleman, 45-year-old farmer who came to you with growth of pinkish mass in the right eye. With the photo that you put is quite fleshy and progressive kind of pterygium.
Yeah, and it's crossing the limbus also.
And
it's
it
not
is crossing the limbus.
Yeah.
It's not the patient's image, okay?
Yeah.
Okay.
So, yeah. So
and on examination, what have you written on examination? The right eye was found to have what pterygium? Nasal pterygium, no?
Yeah.
Nasal pterygium.
You have to mention
that.
Okay, ma'am.
Okay. And the other eye doesn't have, okay, very good. But usually it is seen in the other eye also because the exposure in this eye is equal to the other eye, no?
Yes,
as in, it might still not have developed, it might not develop, but there are chances of it being bilateral.
Okay. So Naveen, it's a gel, okay? Vitreous is a gel, it's not like liquid. It will not flow through your between the zonules. Okay, it's a full jelly, like how you eat your jellies. No, it's just like that. So it's a complete one mass n mass jelly. So it doesn't come through the zonular fibers into your okay, into the anterior segment. Yeah.
Yeah.
Okay.
Okay, so
Okay, so how would you go about
management.
this case? Yeah.
Surgical excision.
Now, what have you written
Management.
in the, wait, just show the next slide. What have you written in the diagnosis?
Differentials.
Yeah, even in the diagnosis, you're supposed to write as right eye nasal pterygium and whatever grade that is also. And
Okay, ma'am.
whether it is progressive or
Yeah, even if you don't
atrophic.
mention the grade, it's okay, but please write nasal pterygium. That is
Yeah.
very important. Pterygium is a very vague term, no?
Okay, yes, ma'am.
Okay, so your
And,
differentials are pseudo, pterygium, pingicula. What is pingicula?
The fatty tissue present in the eye. Fatty mass. Yellowish fatty mass.
But what is it?
It's
Like pterygium is an elastotic degeneration. What is pingicula? Some say it is precursor of pterygium, yes, but what exactly is it? It might not progress to pterygium. So what is it? How do you define it?
okay,
lipoid degeneration.
Lipoid, no.
Elastotic degeneration is your pterygium, okay?
Pterygium, yeah. The
Why
cystic
is it
degeneration.
okay?
You'll find
What do you
something
mean
like
by
cyst.
elastotic and not elastic?
Yeah, very good. I was about to ask this in the end, but then okay, I'm expecting few answers in the chat group. We are not going to give the answer right
Yeah.
away. So please
Yeah.
Google or search or do whatever you want to find out the difference between elastotic and elastic. Why is it not called elastic?
Okay.
Can be elastic degeneration only. Why is it called elastotic?
Okay, yeah. So, yeah. You tell, Aashna, you tell what will you do with this patient?
We'll go for surgical excision in the patient, and
What is, wait. Before, when you say that you want to go for surgical excision, what is the indication for surgery in this patient, your patient?
as of now, it's just cosmetic. It's not affecting the vision, so there won't be any functional problem. But it's just cosmetic as of now.
Okay, the patient wants the cosmetic blemish to be removed.
As the history we saw, the patient is poor and he's old also, so he doesn't want. But
so then you would, when you are asked what will you do with this patient, you would start the answer by saying that the vision is not hampered. It is 6/6. Okay.
Yes, ma'am.
And the patient does not worry about the cosmetic blemish. That means the major two indications for your surgery is ruled out. So
yes,
you would
ma'am.
medically manage it. Medically manage it by what?
Steroid eye drops and antibiotics.
Why do you want to give steroid eye drops?
To cure. No.
What will you cure? Pterygium is not cured medically, no?
Yeah. That's for recurrence. I'm not supposed to give it before the surgery.
Yeah, correct, Naveen. Topical steroids is only to decrease the inflammation.
If it is an inflamed pterygium, you give, okay, fine. But if it is not, then somebody's given the answer in the chat box. Lubricating eye drops.
Yeah, very good. Okay, more often than not, you do not realize the importance of these artificial tears, okay? It's very, very important.
Well, they're more prone for dry eye again.
Yeah.
They'll have that chronic irritation, all that.
Yeah, sunglasses is all protective, okay? Protective. You wear the headgear.
Mitomycin C will come to it later.
After the surgery.
Yeah. No, not, adjuvant to surgeries and all.
Preservative-free vasoconstrictor. Do you mean phenylephrine? Phenylephrine eye drops, something like that? Also, just one more question. This is routinely asked for you people. What is Stocker's line? What is Fuchs spots? All these
parts
things.
Of pterygium. First, let's come to parts of pterygium. Quickly, otherwise we will not go to surgery. 8 minutes.
There's a cap, head, neck, and body.
Okay.
Okay, that's parts, and I think they've answered in the chat section.
Very good.
Iron deposition, few spots as well. Okay, these are some very common things. Okay, one more question. What are the other? If you are saying iron deposition is Stocker's line, what all other things do you know of? Like what other funny names you know of? Just fast, somebody just can type, and meanwhile I'll just tell you what is elastotic. Elastotic
No.
is
They let them give
okay.
it. Yeah, let them find. Whoever finds
Yeah.
it like a genius now, please.
Yeah.
If we can move on to surgeries.
Yeah.
So how?
Ash-
Yeah,
Ashna, you would
Ashna
like
will
to
say.
tell what are the surgeries that you would try in a case, if at all you're planning for the surgery?
The first one is the normal surgical excision, like cutting the neck part and then removing it from there and putting the adjacent conjunctiva over there. If it is recurrent again and again, we perform something called as Mec-Reynolds operation.
That was very old. Mec-Reynolds, okay. What they tell
Okay.
now is the conjunctival limbal autograft. That's what they expect from you. Okay, and when you say there are two techniques. One is usually called as the avulsion technique, and one is superior this lamellar keratectomy. Okay, so when you're doing the avulsion technique, that's when you hold the body and try to avulse it from the cornea. Okay, and
Yes,
you
ma'am.
can use a conjunctival autograft because that also has the limbal stem cells. So you need to read up about how they measure the the autograft that is to be taken, how they put a flap, and how the limbal stem cells are again placed in such a way that it coincides with the nasal limbus again. All right, so this is
Okay,
the
ma'am.
answer that they
Yeah.
expect
So
you to tell.
how?
Okay, so please read about the conjunctival limbal autograft. This surgery is very much important for you all to tell. They might ask you something about limbal stem cells and the deficiency if at all you're answering very well. Okay.
And
Okay,
there's
ma'am.
something called, okay, once we come to this, you have to remove the pterygium, okay? So there are options available. You remove the pterygium and you leave the sclera bare. That is
Yeah.
called bare sclera technique.
Technique.
You don't cover it with anything. There are high chances of recurrence of pterygium in this technique, okay? So then came where you have to cover it. So they would pull along the adjacent conjunctiva and then suture it, okay? One. Then they would do something called rotational conjunctival flaps. They would just rotate one flap and place it over there. You understand by what is rotating? No, at one part of it is still attached to where it is, from where it is present, and the other part is rotated that side so that it covers that area. This part is left bare, the one from where it is taken. Then is autologous conjunctival graft, which most commonly is used everywhere. They take most commonly superior temporal part of the conjunctiva and then place it on the pterygium bare sclera area. So that area will heal on its own. In this area, it is known to prevent recurrences. The other option available is amniotic membrane, which most of you say mucous membrane. Mucous membrane, we don't use it. It's very thick. It is difficult. It is quite disturbing because you have to close your eyelid and all. No, it is not very easy. So amniotic membrane is very thin, which itself acts as a source for stem cells. So in case if there's any stem cell deficiency also, that is also known to prevent your recurrence. Something called perfect surgery. Yes, very good. What is perfect surgery?
Yeah, I was expecting that answer.
Yeah,
Very good, Kunj. What is the full form for perfect? That's the perfect surgery for pterygium actually.
it's an yeah. You can somebody expand perfect.
Yeah.
It's pterygium extension followed
Extended
by
removal followed by, yeah, extended conjunctival transplant. Very good. It
transplant.
was first described by Dr. Hurst in Australia. Okay, you extend like instead of the normal, you take a larger excision.
Okay,
Can you
there's
explain
some.
lazy eye?
Yeah, lazy eye.
Lazy eye.
Lazy eye is nothing but your amblyopic eye. Then everything else is normal. Your eye can still not reach 6/6 vision. That is in spite of having good refractive correction, everything possible done. Okay, so that your fundus, everything is normal. There's nothing wrong in the eye. It is just that the neural adaptations are not developed. So there are many causes for lazy eye. One is your high refractive error in case if you are hypermetropic, most commonly seen in hypermetropic. If you are more and you're not used to wearing glasses from the beginning, then you notice, okay, suddenly you have glasses and you start wearing after your developmental age, that is approximately 14 years. After that, if you start wearing, then you probably can have lazy eye. Squint is also another cause. Then somebody asked, yes, how do we know based on history and examination? In history, you just have to ask, were you able to read, have you visited an ophthalmologist before? And were you able to read with both the eyes till the last line? If he says no, in spite of the glasses being given, the doctor explained me that I still cannot read the last vision. This is the maximum I can read, whatever he is saying. Then that is an indirect way to assess if he has amblyopia or not. Based on your examination, again, visual acuity, If it is not, if you cannot explain your visual acuity why it is decreased, and you see everything else to be normal, it's just that the high power, or it can be squint, or it can be anisometropia, like one eye has high power, the other eye is less. So the lesser one will be able to see 6/6, the higher one, even if you give, like, suppose if the correction is -8 or something, and you give -8, and even then the patient cannot see 6/6, that means he has some amount of lazy eye, that is amblyopia.
Okay, we have
Yeah.
exactly 1 minute left.
So I think, yeah, we can end it.
Yeah, we can almost end it here. Yeah, somebody has written about elastotic enzyme
Yeah.
cannot digest. That is very correct. That is elastase enzyme cannot digest it. But although it stains like elastin, okay?
Elastin.
It just
behaves,
stain like
yeah.
elastin, but does not get digested by elastase enzyme. That's why it's called as elastotic. Shall we end it here?
Yeah, it's actually a precursor of elastin.
Yeah.
Okay. I think
Anything
we can
else you
end.
can, any doubts, anything, you can reach out to the core committee members.
Yeah.
They let us know. We'll text you separately. Okay. Thank you everyone.
Thank you so
Yes.
much.
Aashna,
Thank you,
good
ma'am.
presentation.
Thank you, ma'am.
Akshata ma'am, thank you. And
Thank
all
you,
others,
Ramya. Thank you,
thank you so
Aashna.
much.